No problem. All right. Thank you. Thanks for having me today. I'm happy to be here talking today about the beginning topic in the area of neurodevelopmental disorders, specifically talking about autism spectrum disorder and developmental delays today. Um, so I will make sure my slides are working here. Okay. Before I get started, I don't have any disclosures around this topic today, with the exception of just some of the funding sources for some of the research I'm currently involved in. Today, I'm going to review a little bit about the clinical presentation of autism and developmental delays in early childhood, discussing a bit about overlapping and differential behaviors across the developmental spectrum. Also talking a little bit about co-occurring conditions and a tiny bit at the very end about the service systems here in Massachusetts. I want to start with sort of a broad definition of autism spectrum disorder. And I like this one from the CDC because I think it fits well with the current framework of how we think about autism spectrum disorder in a neurodiverse framework. So their definition, part of their definition is available on the website, talks about autism spectrum as a developmental disability caused by differences in the brain. And I think this definition can be somewhat helpful even when you're explaining the condition to a family or caregiver as well. There's often nothing different about how people with ASD look that sets them apart from other people, but often people with ASD may communicate, interact, behave, and learn in ways that are different from most people. The learning, thinking, and problem abilities of people with ASD or autism or autistic can range from gifted to severely challenged. Some people with autism need a lot of help in their daily lives, and others need less. So I feel like it captures the spectrum nicely in some ways, can be helpful to kind of set us up. Before we begin and dive right into diagnostic criteria, it's always good to kind of set the stage for where we are in terms of the prevalence. 1 in 36 children, according to the most recent information that we have on prevalence, is diagnosed with autism in the US, and 1 in 25 children in Massachusetts. Boys are still close to 4 times more likely to be diagnosed, and autism affects all ethnic and socioeconomic groups. Let's start right in with the diagnostic criteria. There are 2 main domains that we look at when we're considering diagnosis. Those are social communication, broadly speaking, and restricted repetitive patterns of behaviors, interests, or activities. So we'll talk a little bit about what that entails. In regards to diagnostic criteria, in terms of social communication, we're looking specifically at this area of social reciprocity. We're going to talk a little bit more about what this entails specifically in young children, but this back and forth sort of social interactions, nonverbal communication, and the integration of nonverbal and verbal communication strategies. And social relationships, broadly speaking, but this encompasses peer interaction, social relationships as you get older, or other kinds of relationships, as well as play and interest, and the ability to also shift the social context and understand that change in behavior in different contexts. Repetitive and restricted patterns and behaviors, interests, and activities includes repetitive motor, speech, or the repetitive use of objects. It also encompasses adherence to certain kinds of routines or rituals, sensory exploration, sensory reactions, so real interests in certain sensory materials or aversion to specific sensory stimuli in the environment, and particular intense focus or interest in certain topics or certain objects or materials or different kinds of things. In order to warrant a DSM-5 diagnosis of autism spectrum disorder, any of these presenting symptoms or behaviors must be impairing daily functioning and be pervasive across settings. So that really is part of the definition for the actual diagnostic criteria. Let's kind of look a little more in depth about what the clinical characteristics look like in the early childhood population. So this is just, I'm going to show an adaptive checklist here that kind of digs a little deeper into some of these diagnostic criteria. We'll start first with that first domain around social communication and social interaction. And in this domain, you must have behaviors present in each of these three categories. So the first being social reciprocity. And here, what we're talking about, what this really looks like in early childhood is sharing interests, showing enjoyment, sharing emotions, responding to name, responding to the social initiations of others, initiating social interactions with others, and back and forth sort of reciprocal play. So when you're talking about young children, this is rolling a ball back and forth, playing, peekaboo, playing different kinds of interactive games, responding when someone calls your name, responding to the initiations of others to look at an object of interest from across the room. So those initial examples of joint attention or initiation of joint attention. Things of that nature, showing things, holding up toys of interest, giving things because you're trying to share that object with someone else, not because you're seeking help or requesting help, things like that. In the second area that we look at within this broad domain, nonverbal behaviors are things like eye contact, but not just eye contact. We're also looking at gestures, the use of other ways of communicating, and this will be a helpful differentiating factor when we talk about overlapping symptoms of other conditions. So things like, waving, blowing kisses, pointing. Index pointing is kind of an early sign of communication. So that's something we certainly look for in young children. But then also there might be behaviors that might not be expected. So in the absence of some of those nonverbal behaviors, there might be the use of a hand, someone else's hand as kind of a tool, or taking their hand, placing it on an object in order to request that object, or things of that nature. And just overall challenges in this way, but there may be the presence of some of these behaviors in isolation of each other. So we're also looking for how these behaviors are integrated and used with other strategies. So looking and maybe making a vocalization or a gesture when you're making a request, that would be an example of kind of integrating those verbal and nonverbal behaviors. And then, of course, also facial expressions. So not just emotional extremes like happy or frustrated, but really kind of the range of emotional expression. And then the third in this area is relationships, but this also includes in the early stages play, the development of more complex pretend play using objects in place of other objects, and then drawing others into your play. So sharing that play with others. Interests, it may be, if you're thinking about very young children, just the simple interest in peers, the awareness of peers, the observation of peers might fall into this domain. And other things like how do children react when others approach them in different social contexts. Okay, and then the second large domain are these repetitive patterns of behaviors, particular interests or activities. And here we have first, we look at repetitive play. use of language and motor mannerisms that may be repetitive. So here you have sort of scripted speech or echolalic speech, repetitive speech, speech that might be difficult to understand or jargony in some way. Or just if a child has more developed speech, there might be idiosyncratic quality to the speech. So difficulties with learning pronouns when it's not beyond sort of what's developmentally appropriate, or pronoun reversals, things like that. Motor mannerisms, there's a wide range here, and they certainly overlap with lots of other presenting conditions, but important to note here if you're seeing any of these behaviors. And then repetitive use of objects could really look like a variety of different ways, lining things up, organizing them, stacking them, grouping them, or a particular interest in certain kinds of objects and the way they are used. Routines and implementing those routines in a specific way, in a specific sequence. And really the way that this is kind of differentiated is how intense is that sort of necessity to engage in that ritual, and how difficult is it for the child to sort of not adhere to that ritual. So we're considering that when we're looking at kind of the observation of some of these behaviors. But play sequences requiring other people to perform activities in a certain sequence or a certain way, or requiring a caregiver to do things in a certain order with certain objects only in certain ways. Sensory behaviors are new to DSM-5 for autism spectrum disorders, but many people have been working with this population for a long time. This is not new information. So visual inspection or interest, so that's examining things very, very closely from certain angles and certain ways. Those are some of the things that might come up more obviously in this area, but also the sensitivity to different kinds of environmental stimuli, the child that really has a sensitivity to certain noises. Responses to pain or pain thresholds, either under responsive or over responsive in different sensory systems, can also manifest in this way in terms of pain responsiveness. Or sensory seeking, like really seeking out things like reflective surfaces, or mouthing objects beyond what's developmentally appropriate, things like that. And then lastly, this really strong interests. So things like really real focus on certain objects, and maybe objects that would be unexpected for the developmental age. So a real interest in, fans or mirrors, shiny objects, appliances, really intense interest in things that is beyond. So just, my child really likes cars or trains is one thing, but if the intensity of the interest is such that it's really interfering or impairing or really exclusive to engagement with other people or in other activities, that's where it becomes sort of potentially falls into this area. And it can also kind of look like the child that really has to always have an object in their hand at all times while they're playing. So they might be interacting, but always holding objects in their hand, which really limits their ability to interact and play with other objects, or with, because they're really reluctant to relinquish whatever it is that they're holding onto. So I've seen things like that as well. Okay. 1 second. Okay. There was a recent publication where colleagues down at CHOP identified what they've now termed as frank presentation of autism. So they interviewed a number of primary care providers and asked them to identify what they termed as a frank feature of autism. So this was really defined as a behavioral phenotype that really gave rise to this sort of rapid impression of autism. So if you know when a patient walks in your office, yes, this patient likely has autism. It was what were those sorts of features that stood out to the physicians as being likely. And they were able to identify about 40% of patients with this classic profile, clearly autism, obvious autism, were some of the descriptors used. what was interesting about this is this did not correlate with functioning in any way for the individuals identified. And these were some of the common characteristics that they had identified in these frank presentations. So body mannerisms were evident, repetitive language, repetitive behaviors, minimal social overtures, or some sort of unexpected atypical social engagement, decreased eye contact, and difficulties or unexpected patterns of speech or verbal prosody. And there was something about just the quality of these characteristics that stood out to the providers. One note here that I want to sort of just mention, which is not necessarily, we're not going to get into sort of the diagnostic process today, but one thing to understand, I think, is that it is a process. So the best practice process for diagnostic assessment is really independent of any particular or single tool. And I think that's important to note if you do come across diagnostic reports or information, or you might participate in the diagnostic process in some way, that there are standardized tools that are meant to be helpful in gathering information that's helpful in informing that diagnostic decision, but that a diagnosis is really meant to be determined not from the use of any single standardized tool, but with the integration of the results of that information. So the cutoff scores that might be retrieved from one of those ASD specific tools is really meant just to classify behaviors or present a risk range. And that information is meant to then be integrated into sort of this overall best practice kind of process that includes developmental history, understanding of medical history, and information from caregivers, and understanding across an individual's contexts in order to kind of make that overall diagnostic decision. Okay, so let's just talk quickly about differential diagnosis. I'm not going to go into every single differential diagnosis here that's possible in early childhood, but we'll tap on just a little bit. So autism is often in young populations differentiated between global developmental delay. So what are those differentiating features? Well, we already talked about autism having difficulties with social communication and this repetitive restricted patterns of behavior. There's also this typically, not always the case, uneven skill developmental profile. So there's some behaviors, some skills that are well developed, others that are less developed. And that profile is not uncommon. With global delay, in contrast, you will see things, maybe delays in social communication, but they're typically more consistent with overall delays in development. So you're not seeing a stark contrast between social communication and other behaviors. Skills may be developing more slowly, but typically more evenly across domains. Whereas with autism, you tend to see this sort of this uneven profile, where you might have children that maybe even have stronger receptive language than they have expressive language, or stronger cognitive abilities than they have social abilities. So you'll see kind of this differential profile. And it's not uncommon. In a recent study, there were certainly an overlap between autism and global developmental delay, as high as 62% in a recent study of about 500 children, preschool age children. Global developmental delay with autism was quite high in that study. Another differentiating condition is autism and language disorder. So here we see again that with respect to language abilities, we see difficulties with verbal and nonverbal communication. Obviously, we see those restrictive patterns of behavior, repetitive behaviors, which are inherent to the diagnosis for autism. So if those are not present, then you wouldn't be considering autism as a diagnostic condition. And then difficulties in social skills and play skills, regardless of communication. And again, this uneven skill development. In language disorder, you typically see more intact nonverbal behaviors. So one of the differentiating features might be, what do those nonverbal behaviors look like? If a child is struggling to communicate, are they using nonverbal strategies to attempt to compensate? Lots of gestures, lots of eye contact and facial expressions to try to express themselves. Any social and play difficulties they might be experiencing tend to be related to that language impairment directly. And And then there's usually historically this this pattern of delays in speech development. But again, language impairment is an overlapping feature, and there is a high percentage of language impairment present in individuals with autism. And just a quick word, because I think this group is probably quite familiar, and I'm going to be winding down shortly here. Obviously, there are a number of medical comorbidities that need to be considered in the context of autism, some with higher rates in the population, many genetic conditions, neurological conditions, particularly epilepsy, inborn errors of metabolism, allergic disorders, just to name a few. But in particular, sleep disorders and GI conditions. So it's important to know that these often co-occur and also at very high rates in the population. So this will be important to understand and consider in treating individuals on the spectrum. And why is this important? Because obviously, or maybe not obviously, medical conditions can be really easily dismissed in individuals with developmental disabilities when they can't communicate some of the challenges they might be having. They might be presenting differently than another child might be presenting with the same underlying comorbidities. And there might be this bias in attributing challenging behaviors or symptoms that might be presenting as attributable to that primary diagnosis of autism. So we need to be really thoughtful in consideration of any new presenting behaviors and really do kind of thorough understanding of what might be happening, because often these can be treatable and really have significant improvements in quality of life. So just a word about that. And lastly, I'll just end with some graphics about access and care in the state of Massachusetts. Primarily, we know that autism spectrum individuals with a diagnosis are typically referred to intensive behavioral services, usually because of funding resources. Autism applied behavior analysis programs are often the referral pathways for most children. So under the age of 3, once a diagnosis is received, individuals can access through a referral from early intervention directly some specialty services. So these would be the more intensive behavioral services. And these are funded by the Department of Public Health until the child turns 3. Another pathway of care, though, even for children under 3, can also be that the parent may go directly through their insurance provider and access care through home-based or center-based service options as well. So those are sort of the 2 pathways of care, generally speaking, that are available to most in that age range. And then once the individual is over the age of 3, the service systems change. Diagnosis after age 3 would lend itself to school-based services or community-based services, but these aren't mutually exclusive. Often individuals might receive from both service systems. In terms of school-based services, you have in-school services that are provided through an individualized education plan. Community-based services, there might be home-based supports, center-based supports that are typically insurance funded. And the last pathway is a home community services through the autism waiver, through the Department of Developmental Services for those families who might qualify. And then if you're not already aware, some really great resources within our state. And that is all I have.